Today I will be revising the topic on physiology of heart failure. This is one of those what I will say fatal disease or condition. It's not a single disease. It's a fatal condition in which progressively the person enters into the final stage of the heart failure and ultimately death if not treated properly. And we have a very few options for treatment, which we will discuss in due course. Actually, we mainly concentrate on the physiological perspective, not in the clinical perspective. In the clinical perspective, you will be taught about the heart failure on the bedside clinics and in the internal medicine in a detailed manner. Here I am only touching upon areas which concern us and which require physiological explanations. That I would be concentrating upon. Now, first, we just look into the definition of heart failure. If you can see this definition, it is a state in which a heart fails to maintain adequate circulation, that's cardiac output, for the needs of the body despite satisfactory venous filling pressure. The condition, decreased cardiac output and the venous filling pressure is adequate, is either normal, it's not falling. By definition, the conditions in which the cardiac output is low and there is a decreased venous filling pressure, they are excluded, just like a hypovolemic shock. In this condition, the cardiac output is low because of the decreased venous return. Okay, so now we continue the definition. We try to understand the definition a little more because it's more complex than what we try to imagine it. Heart failure represents a constellation, that is a group or constellation of signs and symptoms, that is a cluster of signs and symptoms resulting from the inability of the heart to pump blood forward at a sufficient rate to meet the metabolic demands of the body. This is a forward failure. I repeat here, heart failure represents a constellation of signs and symptoms resulting from the inability of a heart to pump blood forward at sufficient rate to meet the metabolic demands of the body. This is known as a forward failure, or the ability to do so only if the cardiac filling pressures are abnormally high. So ability to do so is what? Ability to provide the pump out the blood. Ability to pump out the blood if the cardiac filling pressures are abnormally high. So that means it's a backward failure or a combination of both. So that means there is one filling problem, the second one is the filling problem, and the first one is the ejection problem, that is throwing out. So now this is the definition of the heart failure. It is a constellation of signs and symptoms. Thus, it is not a single disease, it's a syndrome. Often, it is the final and most severe manifestation of any form of cardiac disease. It's a severe manifestations, and ultimately there is a lot, it leads to the fatality or death. Physiologically, how we define the heart failure? I make it simple here. It is inability of the heart to pump sufficient oxygenated blood to the metabolizing tissues, despite inadequate filling pressure. So that means we have the inability, the decreased pump failure, and this filling pressure is normal. That's what it is. That means failure of the heart to pump enough blood to satisfy the needs of the body. That is metabolizing tissues, making it simple. Making it simple here, it is failure of the heart to pump enough blood to satisfy the needs of the body. The needs of the body is needs of the metabolizing tissues. Now, what is the problem? Here in this slide, we are looking at the problem. Why we are worried? As a doctor, you are worried because it is a chronic disease and you will be encountering them and you have to help them. So just look at these statistics. Affects 10% of the people over 65 years. So that means even in general population, whosoever is above 65, that means 10 of them are going to get it, or they are having it. That's one part. Then look at the second aspect. 50% of the people above 85 years are having heart failure. So that means you can see the persons with 85 plus, the 50% of them, that means 1 in 2 is every alternate person is having a heart failure. That is a very large this thing for this age group. Then what happens? 10% of the patients with heart failure die each year. So that means what this is a statistics according to age. Now, whoever is a heart failure, they die. 10% of them are dying every year. So that is something a great number. And it is the most common condition for which patients above 65 require admission to the hospital. So this is the problem of the heart failure. And just I gave you a bird's eye view on the problem of the heart failure. Now, every 1 in 10 persons of 65 and every alternate persons above 85 are suffering from it. Having known the problem, we move on to the causes. What may be the cause? Okay, so now let us not bother about the heart at this juncture. Now I consider heart as a pump. This is one of the pump, the mechanical pump or a water pump. I'm just trying to show you here. This is a water pump. Now this pump can fail anytime because it fails because of the fuel is not there. Fuel is not available, or it may fail because of the engine failure. That means there are something problematic in the engine, running of the engine, that piston or whatever, the motor or whatever. Or there may be a problem in the pipes and accessories. There may be a pipe. It may be the pump is okay. It is throwing out the water, but the pipes are leaky, or they are not accommodating, or they are giving it back, or there is a closure. So the pipes and accessories, or there may be a problem. Even this may be normal. It is an external problem. Maybe there is no electricity, or there is no petrol availability, or there is some other thing which may crop up that will be producing the failure. So this is we are looking at the water pump, a very simple design. Now we translate the same thing into heart. Now I have put the heart in the center here as I put the pump. Now I come back here. It is the energy, that is the fuel, that may happen because of that there is a deficiency of the fuel, may happen because of the ischemia, coronary artery disease, or a decreased oxygen supply, or whatever. So that means there is ischemia, that is a energy deficiency. Or the engine failure. Engine failure, I want to say, this is a contractile unit, entire contractile machinery. The contractile machinery comprises of those proteins, the electrical activity of the heart, and the other features of the other things related with the calcium and contractile activity of the heart. So that means this is engine failure, that contractile unit. Now the tubes and valves, that means the failure of the valves. First we consider the valves. That means there is a valve which allows the unidirectional flow of blood in the heart and the great vessels. Now if these valves fail, there will be a regurgitation, or if these valves are becoming stiff or stenosed, they will not allow it to get out. So that is the failure of the tube valves. Now tubes, because if the tubes are there is a aneurysm, or there is a coarctation, or there is a narrowing, all those things are happening. This is about the tubes and valves. Then external factors, because this heart is encased in the pericardium. This pericardium allows it a continuous contraction of the heart, and this continuous contraction of the heart, it tries to give the cushioning effect, because continuously the heart is beating, the left ventricle is beating and touching the chest wall. That is what the apex beat we are talking about. So now continuously it is pounding on the chest. So now if there is no pericardial sac or pericardial membrane and the fluid in the pericardial sac, then at any time the heart, the left ventricle would have been bruised and maybe ruptured. So the pericardium, if the pericardium fluid is there, if there is a lot of fluid accumulating in the pericardium, so then it will not allow to heart to contract. Or there are other factors. There is too much gush of the blood into the ventricle. There is a hyperdynamic circulation. This hyperdynamic circulation, that is the external factor, because it is independent. Heart is okay, there is no ischemia, the contractile machinery is fine, the tubes and valves are fine, but the blood flow is more than normal. So these are the four factors related with the heart failure. I have given you a broad view on the heart failure. So individual causes, when you go to the clinical side, you will try to know them, each one of them one by one, okay, as you enter into the next year. Now going to the further, just I am trying to bring back here whatever I have explained earlier. The pump failure, it is because of the decreased energy source, because of the failure of the engine, because of the failure of the tubes and connectors, or the external factors that are not related to these three things, that is the pump, tubes, or the energy. Then heart failure is an analogy, as an example or a similarity translating, is a decreased energy source. Here in the heart failure is the coronary artery disease. That is the what we call it as a myocardial infarction or angina pectoris. Then we have the abnormality engine. Abnormality in engine, that is the heart machinery, that is the intrinsic muscle abnormality that must have produced myocarditis produced by a virus, toxins, genetic, or this genetic may be the cardiomyopathy, that is a enlargement of the entire ventricles. Then comes the defective tubes and connectors. I have already mentioned valvular heart diseases, maybe stenosis or incompetence of the atrioventricular valves or the aortic and pulmonary valves. Then I mentioned about external factors, the restrictive and high output. I mentioned two components, the pericardial effusion and pericarditis, the concerns with the restrictive component, the conditions that increases the circulation, or what is called hyperdynamic circulation, that is a high output failure. In this hyperdynamic circulation, I want to thyrotoxicosis is one of them, Paget's disease, arteriovenous shunt, anemia. Even if you take the anemia, very severe degree of anemia, there is the circulation, the blood is in the hyperdynamic state. So these all produce the heart failure that will not be cope up with. So we go further. So now try to understand each one of them little more. Restricted filling. So that means mechanisms underlying the heart failure. I have made it into 5 categories: restricted filling, afterload, preload, contractility, and electrical activity. In the restricted filling headings, we have the mitral stenosis. That means it's not the blood is not coming from the left atrium to the left ventricle. Or cardiomyopathy. That means the heart cannot restrictive cardiomyopathy. Heart contractility is diminished. It is not able to contract effectively. Or constrictive pericarditis. That means the pericarditis is there, there is effusion, and it does not allow the blood, the heart to contract, that is having a pressure. So that is a constrictive pericarditis that makes the filling improper. So then we have another condition called afterload. What is this afterload? That means there is an increased pressure load on the ventricle. How a pressure load builds up in the ventricle? Because the hypertension, because it has to work against the high resistance. Normally, the left ventricle pushes the blood or ejects the blood against 120 millimeters of mercury, that is the highest systolic pressure. The mean arterial pressure is around somewhere around 93 or 95 millimeters of mercury. So now in hypertension, where the mean arterial pressure increases, maybe systolic pressure may shoot up to 180, 200. So that means it has to pump. There is a load on the ventricles to push blood. So that means there is an opening of those valves, the aortic valves. So is because of these high pressure, they will not open easily. So that means the left ventricle has to pump very severely or very greatly. So now aortic stenosis. Aortic stenosis is the aortic aorta or aortic wall or aortic opening is stenosed. So again, that produces the resistance, that is afterload. Similarly, pulmonary stenosis. Pulmonary stenosis, because the pulmonary valves, it enters into the pulmonary circulation on the right side of the heart. So that also produces the afterload, but that is going. Then another thing, coarctation of the aorta. So there is a sudden narrowing of the aorta. So this may be a congenital disease. So they all produce the afterload. That means when ventricle starts contracting, there is a load which is very severe. Then we have another condition, the preload. So you just look here. The increased pressure load is afterload. Increased volume load is preload. Volume load means the more and more venous return is coming, or more and more blood is entering back into the ventricles. As happens in case of a mitral regurgitation. The mitral regurgitation, what is happening? The atrial and the blood goes back. That means again the blood remains in the ventricle. The aortic regurgitation, this is aortic regurgitation, the blood comes back. Whatever is thrown out, it comes back. Or ventricular septal defect, that is the shunt. Then or tricuspid regurgitation. This is a mitral and tricuspid, or with a left and a right ventricles, or pulmonary regurgitation. These are the components so which produce the increased volume load. And I also mentioned this increased volume load is because of the increased hemodynamic circulation, as happens in case of arteriovenous fistula or arteriovenous shunt, the high temperature, thyrotoxicosis, Paget's disease, and anemia, severe anemia, that also increases the preload. Then we have the decreased myocardial contractility. So that I have already mentioned, it is because of the coronary artery disease or cardiomyopathies, that is, these are abnormalities, or because of the myocarditis. Myocarditis may be because of many causes. The bacterial, the diphtheria is one of those bacterial infection, it produces the endocarditis. So that means that is a very severe on the heart. So diphtheриal toxin or a virus, the venom, the scorpion venom produces myocarditis, or any other toxic thing which produces the myocarditis. So that will be producing the altered or a decreased myocardial contraction. Now we come back altered electrical activity. That means the rhythm generation. The heart beats at 70 beats per minute because of the sinus rhythm. That means SCA node is acting at a regular interval. And if this is altered, so what is called arrhythmia? If this is beating either too slow, bradycardia, or too fast, tachycardia, or not able to cope, fibrillation. Fibrillation is very fast, so not able to cope or produce a ventricular contraction, or there is a conduction defect, that is there is a heart block, the first degree, second degree, third degree. So now you know that the third degree heart block was a Stoke-Adams syndrome, in which there is a total dissociation of the atria and the ventricle, and totally heart is slowed down below 30, or somewhere around 30 beats per minute or something like that. It's very severe. The person goes unconscious. So these are the underlying mechanisms for the heart failure. Now coming back, what are the symptoms of heart failure? The first and foremost is dyspnea. To start with, the dyspnea on exertion, then dyspnea occurs when in the lying down posture. He may be comfortable when he sits up. So that is called orthopnea. So now dyspnea on exertion to start with, because when you start exerting the muscles or when you start doing certain work, the workload on the heart is increased. So that workload it's not able to compensate. So the dyspnea occurs, the breathlessness occurs. Or sometimes what happens, the person goes in the night, goes to sleep. Slowly, there is a buildup of back pressure or back thing in the pulmonary vascular bed. And this pulmonary vascular bed, because of the increased accumulation of blood backwards, it's not coming worse. That's like a backwaters. Backwaters are settled in the pulmonary circulation. So suddenly there is a problem in the ventilation and perfusion. And this produces what is called sudden dyspnea. The person gets up because of the some choking sensation, and he gets up. And once he gets up, he tries to goes to the outside. He was having a air hunger, and he tries to go out. And by that time, when he wakes up and when he changes the posture, this disappears. And but it comes in this attack of the dyspnea comes in the night after going to sleep, and it comes in this as a paroxysm or a spasm, and suddenly it goes off. This is known as a paroxysmal nocturnal dyspnea. It is often seen with the mitral stenosis. Then cough because of the pulmonary edema, pulmonary congestion. Then he comes with the problems of the swollen feet or swollen legs. Or he may complain that his tummy has become a little larger, and it was not before, and it has become there's a lot of, and he may feel the fluid movement, because you have a very peculiar a sound if you have a empty space, the water is moving. That type of a feeling he may come, and he may say that I have a water in my abdomen, or there is abdominal swelling, something like that. Now, this is all because of the excessive fluid accumulation. Now, here we have the coughing, the fluid here in the pleural cavity, fluid here in the abdomen, and the fluid here. And if you are looking at these things, he is tired because the blood supply is, that is the second component. Due to reduction in the cardiac output, there is easy fatigability. That means he is tired, and he is weak, he feels weak, and he does not have the interest, and there is a decreased urinary output because of the heart is not pumping, the pressure is not there, pressure head is not there, so that will reduce the urinary output. See, these are the symptoms of the heart failure. Now, what are the signs of the heart failure? Now, if you try to see this individual, he has a cool, pale, and cyanotic extremities. That means a cold and pale, and or sometimes this cyanotic means the circulation is hampered, so there is the bluish discoloration of the finger nails and finger bed, so they will have the cyanosis that could be seen, and even the tips of the fingers may be cyanosed. So that is one, because of the low circulation. Then he will have a sinus tachycardia, increased rate, and he is having a abnormal sweating response. He may have what is called a diaphoresis, abnormal sweating response, and he has the peripheral vasoconstriction if you examine. Now, if you examine the jugular venous pulse, you will see the jugular venous pulsations even at a very high level. You know how to examine the jugular venous pulsation. You have to make it inclined, semi-inclined, 45 degrees, and then you try to see the pulsation of the jugular vein, and they are seen even up to the at the 45 degrees, even up to the ear level. So it is going on like that. So there is a elevated jugular venous pressure as well as a pulsation. You can see the pulsations very clearly, and the pressure, if you measure, it will be higher. Then you have the pedal edema, the lower extremity edema, and you will find in this person, the examination of the cardiovascular system, you may find displaced right displacement of the PMI. PMI is a point of maximal impulse. So this is the new terminology. It's coming up. It's nothing but the apical impulse. It is the apical impulse. It is called as a PMI in the newer textbooks. So the displaced apical impulse, that is PMI, point of maximal impulse. And this is displaced to the right side. Usually it is there in the midclavicular line, even within the midclavicular line, half inch medial to the midclavicular line, and it is displaced to the left. That indicates the left ventricular enlargement. Okay, so now the respiratory system examination reveals there are decreased breath sounds, and you have adventitious sounds, what are called crepitations. You will see some what is water bubbling, some types of, whenever you are trying to have those typical crackles or crepitations are heard by auscultating. And see, you may find by percussion, you may find the effusion, or you may find the hydrothorax, the pleural effusion in the side because of the whatever the fluid accumulation. Abdominal examination reveals ascites, that is the presence of the fluid in the peritoneal cavity, and also the enlarged liver and enlarged spleen. These are some of the clinical signs of the heart failure. Now, this is one jugular venous pulse I am trying to show you here. So you can see that it has come up to this level. So it is he is in the reclined position about 45 degrees. So it is going up like this. Or you can see the pedal edema. You can just see that he has pressed it and left for some period of time, and then after that you can see this pitting. So this is a pitting edema. There is a depression. You can just see. So he has the pedal edema. These are some of those signs. Now, summarizing what I have said about the signs and symptoms, because these are important for your physical examination point of view, I will just go one by one. So you will find in dilated pupils. The pupils are dilated because in this person there is increased sympathetic activity. That's one point. And he's the entire skin is pale, gray, and cyanotic. So if you are seeing the lips, the nose, and the tip of fingers, they may be cyanotic, and they are all body is pale. So that means the blood supply to the body is diminished, and it is not as reddish as we see. Then dyspnea I mentioned. Dyspnea, so that means I have this one I used to show view. So view means shortness of breath on exercise or exertion. Shortness of breath on exertion is the early symptom of the pulmonary congestion. That indicates that it is getting accumulated, because whenever you are trying to do some exercise or exertion, that increases the circulation, and that would accumulate in the pulmonary side and pulmonary congestion. Then orthopnea. Orthopnea is a condition wherein he cannot lie down. He has to, he can breathe unless only in the sitting posture. So that means he gets up and he does not want to go to the bed in the supine posture. Then I mentioned about crackles, wheeze in the adventitious sounds, because of the air is bubbling up, and a cough. It may be having a sputum there with a frothy pink sputum or a white sputum. That means the expectoration is whitish or a pinkish. That is a cough. The decreased blood pressure, because the ventricles have failed, it's not pumping the blood pressure is low. And this again stimulates the sympathetic system. That is what we have seen here, which acts on the heart to increase the rate and increase force of contraction. So there is a decreased blood pressure. But if you record the radial pulse, you may find increased rate of contraction. So that is one aspect. Now, nausea and vomiting, because of the circulation, the peristalsis slows and the bile and fluids back up in the stomach. So that means that produces a nauseating or a vomiting sensation. So he may throw up. Then there is a fluid accumulation in the peritoneal cavity, what is called ascites. And there is a fluid accumulation in the dependent parts or the lower limbs. Suppose if a person is sleeping in this thing, he may have all the fluid on the backwards. So that is what the dependent parts, that is pitting edema, or it may be on the sacral region or the backside, on the gluteal region, or on the legs. You may have depending upon the posture. The person naturally is anxious, gasping from pulmonary congestion, because of there is already dyspnea. So then hypoxemia, that is resulting in dyspnea. Then he is confused. If there is too much of hypoxemia, there is a confusion and unconsciousness because of the decreased oxygen to brain. Then jugular vein is distended and pulsatile, and even if it is reaching up to the very high level. And sometimes you may find the infarcts in the coronaries, and that may cause a decreased cardiac output. Then overall, he is fatigued, he is weak, and it is associated with the decreased cardiac output. Now, there is, if you are looking at the heart rate, so there is a increased heart rate, and maybe it is increasing faster. That is gallop. That you may hear the third heart sound. S3 may be heard. So now you may have the liver and the spleen enlarged, and the urinary output is decreased. So this chart gives you the entire signs and symptoms of the heart failure. I have taken a little more time here, and you try to look into this again whenever you have time, because this part is also necessary for your general physical examination, and as well as the cardiovascular examination, which we try to concentrate during your practical examinations. Now coming back, the classification of the heart failure. Now how we want to, how that heart failure is classified. Now, depending upon the duration, whether it is acute or chronic. So now I have given one example here in between. So acute is a cardiogenic shock, something which is immediate, maybe bacterial toxins or any toxins they will produce, or even the heart, the myocardial ischemia, that is a cardiogenic. So that is acute causes. Chronic for any chronic disease of the cardiovascular system. Now, another thing, which side, which ventricle, left ventricle failure or right ventricular failure. So if the left ventricle fails, there is the entire body suffers. That means systemic circulation suffers. If the right ventricle fails, it is the pulmonary circulation which fails. We just see that the left ventricular failure is associated with the ejection. This is EF is ejection fraction, decreased ejection fraction, and heart failure. That means reduced ejection fraction, heart failure. That is a left ventricular failure. So left ventricle is not able to contract. There is a decreased stroke volume, and there is a decreased fraction of the blood entering into the systemic circulation. In case of the right ventricle, ejection fraction is all right. The ejection fraction is preserved, and the heart failure is there. So that means preserved ejection fraction. Hope you try to understand that. So the normal ejection fraction, I will talk maybe in the subsequent slide. I will talk about that. Normally we eject 70 ml of the blood out of 120 ml. In case of the left ventricular failure, you are only throwing out 30 ml or 20 ml or maybe 50 ml. So that means you are throwing a less amount of blood than what is expected. So the remaining. Here, the normal 70 ml may be coming. It is coming. Then biventricular failure. So that means both the ventricles, the right and the left, both fail. So this is known as a congestive heart failure. Now, then we come back here. I have seen the acute and chronic, left ventricle, right ventricle. So then systolic and diastolic. Again, in the systolic dysfunction, there is a decreased ejection fraction. So that means it comes to the left ventricular failure, systolic dysfunction. Diastolic dysfunction, because of the rigidity of the ventricle to relax, the ejection fraction may be all right, but the heart is not able to relax. Heart is rigid, it's not able to relax, and if it's not able to relax, so there is a problem there. That is a diastolic dysfunction. In this case, ejection fraction may be normal. Now, high output failure and low output failure. So now I have considered here high output failure is seen in hyperdynamic circulation. I have mentioned them again. I will repeat: thyrotoxicosis, where there is a increased hemodynamic circulation. Paget's disease is a bone disease, so that also increases the hemodynamic circulation. Anemia, because I'm talking about anemia which is very severe, in which there is an increased hemodynamic circulation. The normal situation like a pregnancy, there may be a greater circulation rate because of the pregnancy, or arteriovenous fistula in the body, so that will produce the hyperdynamic circulation. Okay, that is one component. The second component, low output failure, is because of the ventricular dysfunction. And these ventricular dysfunction, because of the low output, low cardiac output, or maybe because of the extra cardiac causes. Okay, so now I have classified them: acute, chronic, left ventricle, right ventricle, systolic, diastolic, high output, and low output. Maybe we will move on. Here, what are the classification of the heart failure? How the heart failure is classified? The heart failure, according to the New York, the Hypertension Association or Heart Association, New York Heart Association, they have given the guidelines. I will just go one by one here. They are classified as class 1, 2, 3, 4. In some American Heart Association, they have given it as A, B, C, D. That means heart failure, A class or B class, C class or D class. Now, what happens in the class 1? Class 1, according to the NYHA, that is the New York Heart Association. So these persons are asymptomatic. They do not have any problem. They have come for the routine checkup. Now, what you have discovered some abnormalities here in the cardiac reserve. And the cardiac reserve is less than 400%. And then you looked into the ejection fraction, it was less than 50%. Now, come on, let us see what is this cardiac reserve. The cardiac reserve is the amount of blood. So I will just go back here. It is the reserve capacity of the heart to perform to its maximum. That's cardiac reserve. The maximum cardiac output achievable during exercise is taken as a maximum. So that means the cardiac output which we can achieve during severe exercise is taken as maximum. So normally we have the cardiac output 5 liters per minute. Now during severe exercise or more severe exercise, the cardiac output increases 25 to 30 liters per minute. 25, I have written here 25 to 30 liters per minute. It may go, cardiac output go as high as that. And this is considered as maximum. Now what I have done here, the cardiac reserve is equal to maximum cardiac output, that is 25 liters here I have mentioned. And the normal cardiac output is 5. 25 minus 5 divided by the normal is 5, that is 400%. If you are looking at 25 minus 5 is 20, 20 divided by 5 is 4, 4 into 100 is 400%. So that is the cardiac reserve. Normally it is more than 400%. It's about 4 to 500% of the normal. Okay, it's in a normal situation. Now, if I were to look at the stroke volume reserve, so stroke volume is normally 70 ml, it increases to 120 ml. That is the maximum. No, the maximum cannot be achieved because ventricles cannot empty everything, all the 120 ml of the blood. So some 10 ml remains. So that means it may reach up to 110. That means 40 ml is the stroke volume reserve. If you are looking at that, 40 ml per stroke. Now heart rate reserve. So if you are looking at the heart rate reserve, heart rate is normally average is 70 beats per minute, and it can reach up to the 200. But usually the heart rate is highly variable thing. So now it depends upon the age. The normal maximum heart rate achievable by an individual is equal to the 220 minus the age. 220 minus the age. Say for example, the heart rate an individual with a 20-year-old young adult can reach is up to 200. Same thing, the person with 60 years, he can achieve up to 140. That means 180. 220 minus age is 160. 160 he will achieve. So that means 220 minus age is the maximum achievable heart rate. So now here the heart rate reserve is how much it is? 130. 130 is the heart rate reserve. Now come back here. So now I come back here. So now what they saw, so the cardiac reserve less than 400%, ejection fraction. Now I have written the ejection fraction here. It is the stroke volume divided by end diastolic volume times 100. Now I have placed here stroke volume 70 ml and the end diastolic volume is 120 ml times 100 is somewhere around 58. Normally it is about 58 to 60 or 62%, depending upon the stroke volume and the ratio. So if it is below 50, it is asymptomatic heart failure. So these are the persons, class 1 are the persons who have come for a routine checkup and they did not have any restrictions. And when they have no restrictions, you have identified their cardiac reserve is lesser than 400 and their ejection fraction is diminished. Now, the mild heart failure, that is class 2. This mild heart failure, their activity is limited, slightly restricted, so they cannot do. So that means whenever they try to do the activity, they will have a dyspnea or breathlessness, and they are easily fatigued and they are tired. And if you look at the cardiac reserve, it is less than 300. Okay, that means it is between 300 or less. That means 200 or 100 to 300 is the cardiac reserve, and ejection fraction has diminished to 40%. 40%. Normally is ejection fraction is 60%. Now it has come to 40%. Now moderate, that is class 3, moderate heart, degree of heart failure, there is a marked restriction on the activity. And these persons have dyspnea even with the routine work. That means getting up or doing something, he will have a dyspnea. And cardiac reserve is drastically suffers. So that means 400. Now it is coming about 50 to 100%. So that means it has come up only whatever the 5 liters or 10 liters. That's 25. Where is 25? Where is 10? So diminished drastically, and ejection fraction is only 20 to 30%. That means 60% is normal there. So that means half of the basic ejection fraction. Now in severe cases, that is class 4, the dyspnea, your activity are restricted very severely. He is dyspneic at rest, and he cannot do any work, and he is breathless, and there is almost practically no cardiac reserve. The ejection fraction is less than 10%. So these are the classification of the heart failure. So I mentioned I took this cardiac reserve. Now this may be, you may want to see it, you may want to study it, the cardiac reserve. It's the reserve capacity of the heart to perform its maximum. I mentioned how to calculate. I mentioned about a stroke volume reserve. I mentioned about a heart rate reserve. And you again try to go through this slide. Maybe tomorrow I may upload this